Okay. What about the GI effects of cholinergic? Okay. What was Pansy doing? Okay. Sitting in bed. Okay. And eating and drinking, and it gets the GI system going. It stimulates the GI system to digest, rest and digest. Increase in activity, increase in motility, increase in secretion. Okay. Just like the pansy, right? Think about that. So it increases that. What about on the eyes? Okay, the effect on the eye of the cholinergic agonists, okay, is to cause meiosis, contraction, and lack of accommodation of the pupil, okay, and accommodating yourself to light and all that kind of stuff. It also decreases the intraocular pressure, okay. So some drugs that treat glaucoma are cholinergic drugs because they decrease the pressure that's in the eye, okay, but they cause that meiosis or contraction of the pupil. What about if we overdo it? So let's think about what the PANS does, okay? And I think your book talks about slud, but we've increased it to sludge. Okay, it's easier to remember, but it also has that effect, okay? So this is our guy with the toxic waste here, okay? You can see it's got the toxic symbol on there, all right? And if we have an adverse reaction or an overdose of cholinergic drugs, it can cause this excess or this toxic reaction. So we get salivation, the S, lacrimation, which is our lacrimal glands are our tears, all right? Salivation, lacrimation, urination, defecation, GI distress, okay, not just mobility, but distress, motility, and emesis, which is what? Vomiting. Emesis is vomiting, okay? And antiemetic keeps you from vomiting, okay? So sludge. So if you only remember PANS and sludge, which is kind of the excess, salivation, lacrimation, urination, defecation, GI mobility, and excess again would cause vomiting. The drugs don't cause all of that used in normal doses, okay? But their toxic effects are an exaggeration of their effects that we use them for. So if somebody doesn't have good saliva, okay, or good GI motility, they might give them a cholinergic drug, a PANS drug. But if you give too much, this is what happens, okay? In high doses, toxic doses, can actually cause neuromuscular paralysis. Because even though if a drug is like specific to, say, the muscarinic receptors, but you give a lot of it, it might also affect the other receptors, okay, when you get to toxic doses. So, and this is something that we learned about, actually, I don't know if I mentioned it later, but in people that work in agriculture, and they're out there and they're spraying plants, okay, with different types of chemicals, and the agricultural workers have been subjected to these effects because those chemicals work like cholinergic drugs, okay, and it can be toxic to them to have these effects. Okay, so what are some of the uses? Well, we already talked about the effect that we have on intraocular pressure, okay? So pilocarpine, we already talked about that being a salivary stimulant, okay? It also helps to stimulate the production of, or the loss of fluid from the eyes, okay? It gets rid of the intraocular pressure by getting rid of some of the fluid by it going out of the eye, and that's one of the effects it has. So there are drugs that are for saliva and for the eyes that have the same name, but they have different effects. What about xerostomia? We already talked about pilocarpine. It's cevimeline, okay? It's a muscarinic receptor agonist. See, now we know what that means, right? Stimulates the saliva, but used in excess, we can get that PANS excess, the sludge, chills, rhinitis, flushing, perspiration, okay, which is a SANS effect, but that's a toxic effect, okay? People that have urinary retention for one reason or another, maybe from a drug, maybe from surgery, might be given this drug, uricoline, okay? And sometimes they give it to people, you know how they kind of stop you up for surgery or whatever? They sometimes give it to people after surgery. If you've had surgery, you know, the first thing they'll ask you is like, did you urinate, did you go to the bathroom or whatever, because they know your system's working again. And they might have to give you something like that to get you started again. What about the indirect, okay? The indirect cholinergic agents, cholinesterase inhibitors, okay? The physostigmine we talked about. If you have toxicity from anticholinergic agents, okay, and other agents with cholinergic, anticholinergic action, they may give you that drug, okay, to counteract its effects. Malathion was the drug I was trying to think of before with the agricultural workers, okay, is an insecticide for mosquitoes. I actually remember having really bad mosquito problem when I think it was back from Massachusetts or whatever. But there was a year with really, really bad mosquitoes, and they were worried about people catching mosquito-borne diseases, okay? And they were going around, and like during the night, we'd hear them spraying the trees, you know, for the different bugs and the mosquitoes and stuff. And it's a wonder that we didn't have all kinds of effects from that. But that sludge can happen to the agricultural workers that breathe in too much of this. If anybody remembers, a number of years ago, I want to say it was between 10 and 15 years ago, there was actually, in Japan, terrorists actually released sarin into a subway. And it is an irreversible cholinesterase inhibitor, so people actually kept having these sludge effects, and it can't be reversed, and you would be dead within 10 minutes. So this is a nerve gas. Does that sound familiar?
Yeah.
This is this is a nerve gas, and it's completely irreversible, and it is fatal. So it's colorless and tasteless. So I guess it's perfect for people that want to wreak havoc. What are some contraindications for the cholinergic drugs? What about someone who has bronchial asthma? What do the cholinergic agents? What kind of effect do they have on your lungs? Bronchoconstriction. So would you want to give a cholinergic agent to someone who has asthma?
No.
No. Okay, so when we talk about some of the cardiovascular drugs, if we tell you that they have a parasympathetic effect, you would know that that wouldn't be a good one. So they have designed drugs which are more selective for the different types of receptors. For people that have hyperthyroidism, they can risk atrial fibrillation. For people that have an obstruction in their GI, if this causes increased motility and production of products that need to be gotten rid of, that's a problem for people that can't get rid of them, right? Okay. In people with myasthenia gravis, which is a muscular disease, you would probably know more about something like MS. Okay. This is kind of similar, but not the same. The nasostigmine, which is a muscle relaxant, okay, can cause a problem. And for people with a peptic ulcer, if it stimulates the GI tract to produce all of this kind of stuff to digest, this can increase the problem of their ulcers. So those are some cautions with that. Okay, now we're going to talk about anticholinergic. Okay, anticholinergic, parasympatholytic agents. Okay, so they prevent the effect of this acetylcholine, which is released at the postganglionic to the tissue. Okay. So the acetylcholine, okay, is not blocked, and the receptor site is competitively blocked by the drug, okay? So they're also called antimuscarinic because they block the muscarinic receptors, okay, in the heart and the glands and the smooth muscle, okay? So the acetylcholine is released, and the anticholinergic drug blocks the receptors and prevents the acetylcholine from having its action. Okay, it prevents that from having its action. So anticholinergics, okay, may produce a stimulation or a depression depending on their effect, okay, depending on their dose. And the effects are also dependent on lipid solubility. What do we know about lipid solubility? To be taken up by, to go through the barriers and be taken up by the tissue. Do we want them to be lipid soluble?
Yes.
Yes, okay. So the atropine, okay, that eye chemical that we talked about, the eye drug, okay, and scopolamine, which is used for motion sickness, do cross the blood-brain barrier, okay, so they can have their effects. Okay, so pharmacologic effects here, when we talk about, this is going back to what we learned last week, if something is charged and water soluble, okay, it's going to cross through the barrier or not?
No.
It's going to be blocked. If it's uncharged and lipid soluble, it's going to cross through the different body membranes and have an effect, okay? So the more lipid soluble, uncharged it is, the more it's going to cross over, okay? So, pharmacologic effects of anticholinergic, okay? So if the cholinergic effect is to increase the salivary glands to produce saliva, anticholinergics reduce it. So maybe there's going to be a long procedure where the mouth needs to be very, very dry, so an anticholinergic drug might be administered, okay? It limits the flow and the volume of the exocrine glands which release the saliva, okay? So it's used therapeutically to decrease the saliva flow for a short period of time. Yes, Layla?
Back on this slide, we need to know the book when it shows that the book talks about tertiary and quaternary.
No, tertiary and quaternary you don't have to worry about. Nope, don't worry about it. That's just giving you some more background information. Yeah, it really is not needed, and that's why I didn't include it.
Oh.
Yeah, absolutely not. Okay. What about the effects on the smooth muscle? Okay. Well, if the cholinergic drug, okay, causes constriction of the bronchioles, right? An anticholinergic would cause
Dilation.
dilation, okay, bronchodilation. So ipratropium, okay, is an anticholinergic agent which is used to treat asthma. Makes sense now, right? Look, we're using a drug and we're having an effect and we know what that means, okay? What about people that have IBS because they have all this craziness going on in their GI system, okay? Spasmolytic agents, stopping spasms, right? Lytic means stopping, destroying that effect, are anticholinergics, and they reduce that GI motility to prevent people from having to run to the bathroom every 5 minutes. Okay, they reduce that effect. Anticholinergic. Starting to make sense. What about the eye? Parasympatholytics, okay, cause dilation of the pupil because parasympathomimetics, okay, or our body's own chemicals cause them to constrict, right? So parasympatholytics can dilate the pupil, okay? So, and they can also, they also will paralyze the eye itself, okay, if you will. Remember that accommodation, the movement. So those are useful for someone who's having an ophthalmologic exam or surgery. I have to admit to you that eyes are the only thing I'm squeamish about. So like if they ever had to do eye stuff on me, like, and I sit there with my, like, just, you know how people come in, you've already experienced it now. They come in and they sit in your dental chair, before they get in there, I hate the dentist, I hate having my teeth clean, I hate this, I hate this. I go to the eye doctor and I'm like, I'm gonna be as brave as I can. You just hold my eye open if I'm trying to close it, and I sit there and I'm like this the whole time, just trying to do something. I'm like, it's the only thing, it's like, rip open my gut, give me an IV, I don't care, don't touch my eyes. I don't know what it is about that. But they do use these drugs to prepare you for an ophthalmologic examination. Okay. What about the cardiovascular effects, okay? They use them with general anesthesia in large doses to prevent the myocardium from slowing down during general anesthesia, okay? Keeping us alive. With small doses, like the doses we talk about with some of the drugs, we get that bradycardia, okay? But large doses can have an opposite effect. You see why I don't like to be very prescriptive about that? Okay. What about adverse reactions of anticholinergics? Okay. Adverse reactions are extensions of their pharmacological effect. Okay. So if we use something which is going to dry up the saliva, we're going to cause a dry mouth. Hello. If we use something which is going to keep the pupils from accommodating, okay, we're going to blur our vision. We're going to be sensitive to light. We go out of the doctor's office with those granny glasses on, right? Okay, they give those neat little things to look at. I'm really light sensitive as it is. So, photophobia, okay? Tachycardia, fever, Urinary and gastrointestinal stasis, because we've kept it from moving, anticholinergic, okay? Fever, hot, dry, flushed skin, again, these are toxic effects, okay? And we can cause a CNS excitation because of toxic effects too. When we talk about toxicity, it's very, very complex, all right? It's not just the opposite effect of what the drug would have, right? But mostly it's extensions of the pharmacologic effect. And most of these totally make sense. So what are some of the uses, okay? Preoperatively, we might use it to inhibit the saliva, okay, and the bronchial mucus. We already talked about the GI disorders, IBS, ulcers, reduces the secretions, reduces the motility. Ophthalmologic examinations, wake up, there's your thing there. We all use that one. So we talk about the atropine, already talked about. The cycloplegic eye drops, relaxes the lens, keeps it from moving. And scopolamine, which is a CNS depressant, is also an anticholinergic drug. What are some contraindications, okay? Glaucoma is two kinds, wide angle and narrow angle. The narrow angle is very rare, but we would want to know that somebody had that if we were going to prescribe an anticholinergic drug. For men, if they have prostatic hypertrophy, a disease of the prostate gland, we would want to be aware of that because it can have a negative effect there. Again, that intestinal or GI obstruction, we'd want to be aware of that. And for those with cardiovascular disease, anticholinergics can also block, remember we talked about the vagus nerve, okay, which is very complex in how it affects the body. They can actually get tachycardia. So these are some of the things you'd see if you looked up. So say the dentist talked about this person having a lot of saliva and they wanted to give them a drug before they did this long procedure, and you looked up the drugs that they were taking and you found out, you know, or from their medical history they had any of these conditions, it might be contraindicated for these different reasons. And you don't have to completely memorize all of this with every drug that you learn. You know, you have resources to look this information up, okay? But know that it has this effects. Drug interactions, okay? If you take many drugs that have anticholinergic effects, okay, and you use other anticholinergic agents, it can have an added effect, okay? So some of the like antihistamines that you take, tricyclic antidepressants are huge with that. They can be additive with the anticholinergic drugs, okay? Symptoms would include, and you might expect this, urinary retention, blurred vision, acute glaucoma for somebody with those problems, okay, bowel obstruction, all the things we talked about. Okay, what about some of the nicotinic agonists and antagonists? Nicotine, okay, is actually considered an ANS drug. We know that nicotine is a drug. Nicotine is toxic, okay? If it were by itself and you put one drop of it on your skin, okay, it could actually be fatal. That's how strong this drug is. In low doses, like in smoking a cigarette or something, it produces stimulation, okay? In high doses, it can actually cause you to stop breathing, okay? Respiratory paralysis. Nicotine peripherally can increase your blood pressure, your heart rate, your GI motility. Ask anyone who smokes a cigarette, okay? If it affects their they'll tell you that it affects their digestion. They'll smoke a cigarette after eating. Okay, it does have that effect. Okay, but it constricts the blood vessels in the extremities. Okay, because it's concentrating on its effects in the GI tract. So that's the effect of nicotine. It is considered an ANS drug. Okay.